Thank you and holiday greetings. Let's go ahead, Dr. Trani, and thanks again.
All right. Thank you for that kind introduction, Mark. And thanks for the invitation to come back and speak. So we're going to talk about kind of basics of vascular surgery care today, and kind of for the people out there who are thinking about referrals, I tried to make this a very kind of talk where you get the idea, where you should have the flavor of, you know, what you should be doing in terms of a basic workup, differential, and then when you're making that next step to refer to a vascular provider for, you know, additional consultation or thought into patients' problems. So by way of disclosures, I serve as a consultant for Cook Medical, device company, mostly in the aortic side, training new clinical people. My own personal disclosure is that I realized last minute that that I spoke to you all last year, and so I spent the last couple of days kind of creating new slides which better kind of reflect this talk as opposed to showing the same talk last year, that in between a couple of long OR days. So and quality of slides may vary throughout this conference. So by way of outline, we'll spend a good amount of time talking about veins and venous processes, in part because that's a good chunk of what we see on the vascular outpatient side. And then we'll dive into some of the arterial things, and the three most common arterial disease processes that we see in terms of referral are lower extremity peripheral artery disease, carotid and vertebral disease, and everybody's favorite, abdominal aortic aneurysms. All right, so starting with venous insufficiency, if you look at the vascular literature, when we talk about venous disease, the classification system that we use in terms of nomenclature so that we're all talking about the same process and we can kind of track it through time or outcomes, is something called the CEAP system, CEAP. The important one here, I think, is really the C part, which is clinical. And that has a classification of C1 through 6, and that's kind of outlined in the cartoon here. So the C1 are spider veins or telangiectasias, and those veins are very superficial, actually in the dermis itself, sub-millimeter veins. And for the most part, people don't think that they are clinically significant, except with the exception of cosmesis. After that, C1 are visible varicose veins, but really with patients that don't have any symptoms. And then, I'm sorry, that's the C2 with the varicose veins. And then C3 is really where you start to get into clinical symptoms. So they're varicose veins with symptoms, pain, swelling, leg heaviness. C4 is divided into two groups. There's a 4A, which is skin discoloration or hyperpigmentation in a gator distribution. And then C4B is something called lipodermatosclerosis. So what you see in lipodermatosclerosis is scar tissue that forms around the ankle of the vein, and then that goes up for probably 3 to 5 centimeters, and then after that the rest of the skin is relatively normal, and so you see this blossoming or blooming of the rest of the edema up above that level. And sometimes it's described as an upside down wine bottle, but what's happened in that process is that scar tissue is the body's response to the chronic edema that's occurred as a result of the venous insufficiency. C5 is a healed venous stasis ulcer, and then C6 is an active venous stasis ulcer. And so when we think about the pathophysiology of the disease process, I tell patients that the venous system, unlike the arterial system, is a high capacitance, low resistance system. Venous pressures typically at the ankle are somewhere in the 30 to 40 millimeters of mercury range, and they go to 0 to 5 or 6 when you get up into the heart. But as a result of that process, and without a pump like the heart to push the blood back up, really the veins are relying upon the valves, which serve as one-way conduits to make sure the blood heads in the right direction. So when you have venous insufficiency, those valves are broken or incompetent and allow reflux or blood traveling in the wrong direction. The major drivers of venous insufficiency or reflux include family history, a history of venous thrombosis, which induces or produces scarring of the valves and inability to close, pregnancy, and to some extent obesity or any other process which increases intra-abdominal pressure and therefore increases the amount of pressure required for the blood to travel out of the legs. And so what the veins do when they can't efficiently push the blood back up to the heart is that they dilate and they hold on to more blood, and that increases their capacitance. Oops. And so when people are referred to me for venous insufficiency, I really think about 3 areas to try and confirm that diagnosis. The first are symptoms. And when I talk to patients, I really try and get a good history from them in terms of their symptoms, when the symptoms started, if there were any inciting events that initiated their symptoms, and then ask them to kind of describe their symptoms. And typically for venous patients, they should have pain that's maybe in the 2 to 3 out of 10 range. That pressure, heaviness, and swelling that most patients describe, which are kind of non-specific but are pretty classic for venous processes, should gradually build throughout the course of the day. So patients who complain of leg pain, which is worse later in the day, and that swelling increases as well. Typical things should improve that: rest, elevation, going to bed, because they're all really kind of combating the effects of gravity. If patients have swelling in their legs or extreme pain, like 8, 9 out of 10, things that inhibit them from being able to walk, or that swelling is the same in the morning as it is in the afternoon, you kind of have to wonder whether or not venous insufficiency or reflux is the right diagnosis at that juncture. After that, physical exam certainly plays a role. Some patients may have visible ropey varicose veins, as these are kind of branch varicosities that are typically feeding into the main superficial veins, i.e. the great or small saphenous veins. Also look for other clinical signs in skin, like the hyperpigmentation or the lipodermatosclerosis of the C4A and C4B patients, which really, again, make you think that venous disease is playing a role. And then finally, the imaging ultrasound really helps to confirm that diagnosis and also guides management. So the ultrasound generally has 2 components. First, there's the thrombus component, and then there's the reflux component. And when I talk to patients about their ultrasound, I usually tell them that, in my mind, reflux is pretty binary. Either you've crossed the threshold or you have not. There's not literature that says that if your reflux time is 5 seconds as opposed to 2 seconds, that 5 seconds of reflux means that you are clinically more symptomatic than that patient with 2 seconds of reflux. Additionally, if you've got reflux in the deep and superficial systems, there's some data out there that says you can still treat the superficial system and provide patients with some improvement. That being said, that they will still have probably some amount of edema that occurs because the deep system is incompetent as well. And the last thing you're looking for really is thrombus. Most patients don't show up with thrombus as opposed to reflux when they get referred. But if you have thrombus in the deep system, that's always a contraindication to treating the superficial system in terms of an ablation strategy. And the reason for that is if your deep system is compromised, when you close the superficial system, you're pushing everything into the deep system. And so you need to make sure that that's working and functioning appropriately. There it is. So we all know that compression stockings are the kind of the first line treatment option. 20 to 30 millimeters knee high is totally appropriate. You don't need to be thigh high or pantyhose to have the benefit or effects, because really most of the blood that pools is going to be in the most dependent location. So that's in the calf, and protecting the calf and preventing those veins from dilating is the goal. So the knee high is fine. Some patients complain about the band below the knee, so you can talk to them about that, but you should let them know that they can wear thigh high to avoid the band at that level. The disadvantage with thigh high is they're a little bit more cumbersome to put on, and that band will tend to slide down, so they need to kind of work it back up during the day. The other benefits of compression stocking, which are maybe not as obvious, are number one, insurance. So most insurance carriers expect patients to go through 3 months of conservative therapy before considering an intervention. And that's fine. That's just a box to check off. But the other thing that the compression stockings do, in my mind, is it really predicts future success. So when we talk about symptoms, again, they're pretty non-specific. But if you have patients who wear a compression stocking and they really derive benefit from it, meaning their legs feel better later in the day, you've reduced their edema, and just in general, they feel like the stockings have had a positive outlook in terms of their overall quality of life. 80 to 85% of the time, some sort of an intervention on their varicose veins will provide them with relief of symptoms. Whereas if they say, yeah, I tried the stockings, but I didn't really feel like it made much benefit, I usually tell people that the likelihood that treating them with an intervention and providing them with the relief of symptoms decreases pretty significantly, down to 50-50 at best. And for some patients, certainly no guarantee of an improvement with an intervention causes them to kind of reconsider. And you should also think about other things on your differential. The bottom right slide just shows a sheath and a radiofrequency catheter. So these procedures, for the most part, should be done in office, take 30 to 45 minutes to do, or done with just some local anesthesia and ultrasound guidance. So how good are therapies? So for about a century before radiofrequency ablation came along, vein stripping, going to the operating room and physically pulling out that vein was the standard treatment for venous insufficiency or reflux. Recurrence rates are pretty high, 20 to 80%. And then RFA came along in 1998, and soon after laser, which kind of does the same thing, closes the vein via a thermal mechanism. When you look at reasons for treatment, pain, fatigue, and edema were the primary symptoms. And then when you look at occlusion over time from 1 week up to 5 years, the occlusion rates with radiofrequency are pretty excellent at 96.8 or just about 97%. And you just about completely eliminated reflux in those patients. When you get it out to 5 years, the occlusion rates are still excellent at 87.2%. Reflux does recur in just under 20% or 83% of patients. And that's typically due to branch varicosities. Anterolateral thigh branch is the most common vein that you see with reflux coming just off of the saphenofemoral junction. And when you look at patients and success based on symptoms, you see, again, excellent long-term results. So pre-op, majority of patients were treated for pain, and 40% of those were treated for edema, and recurrence rates at 5 years are all less than 10% for any of those symptoms. So if you have a patient who doesn't quite fit the venous insufficiency box, what are the other options? So I usually spend time talking about 3 different categories and kind of working through that differential. So with venous disease, we've talked about reflux. Venous thrombus is the other thing that can produce symptoms, pressure, heaviness, and swelling. Should pretty easily be diagnosed with ultrasound. Edema and lymphedema I kind of put in one large box as well. So lymphedema can have primary or secondary causes. Secondary causes are generally as a result of surgical intervention where the lymphatic system gets transected. Sometimes that lymphedema is a permanent condition. Sometimes your body is able to kind of reroute and make things better over time. The primary lymphodemas have a couple of kind of modal peaks. The first starts in the teens and extends through the 20s. And then the other starts in the 40s and extends into the 50s, but even as late as into the 70s. I frequently see patients with inflammatory conditions, so autoimmune can certainly be a big offender. Arthritis is probably the most common in that setting. Injury, so people who have had injuries, edema is part of that kind of healing process, and kind of talking to them about injuries, even if they're long-term, like a fasciitis, cause swelling, which can take a long time to recover. And if you just don't know, sometimes it ends up in the idiopathic box, which is pretty unsatisfying, but certainly something that is not uncommonly seen and or discussed. And then systemic causes, cardiac, heart failure is probably, again, number one. You can also see pulmonary hypertension. Both can be diagnosed with an echocardiogram. Hepatic issues, cirrhosis, portal venous thrombosis, and along with cirrhosis, basically just lack of albumin, so you just lose your oncotic pressure. Renal, I've seen 1 or 2 patients in my time with protein-losing nephropathy, which you can generally diagnose on a UA. Renal insufficiency, so you just have a difficult time with your fluid electrolyte balance. Nutrition can play a role, so if you have a patient who's in general pretty malnourished, again, it's that oncotic pressure that leads to the edema. And then medications, probably the number one there is calcium channel blockers is the biggest offender. Things that I do to kind of differentiate venous from edema, lymphedema, and systemic. So systemic causes, I would expect almost uniformly to be bilateral. So if you have a unilateral, it's probably not going to be a systemic. If it's in a lymphedema, I think about lymphedema differently than venous, mostly because the lymphedema tends to extend down onto the dorsum of the foot, whereas the venous edema tends to kind of concentrate itself mostly around the ankle. And then the inflammatory ones, if you've got knee arthritis, that edema tends to kind of, again, stay mostly around the knee, and it doesn't really extend that much further down. Also looking for those other skin clues. Skin discoloration makes me think a little bit more venous than edema or lymphedema. And then in terms of skin breakdown, the venous ulcers tend to occur in the setting of that hyperpigmentation, and lymphatic, you can have areas of breakdown that tend to be maybe a little bit higher and just tend to drain lymphatic fluid for long periods of time and take a long time to heal without adequate compression therapy. Changing gears a little bit, referral that I received recently. In September, a patient had an ultrasound which showed acute thrombus in the posterior tibial veins. The rest of the deep and superficial venous system were normal. November, the patient was sent back to an ultrasound lab, had foot surgery in September, and then thereafter had the pain, which led to the first ultrasound. Was started on anticoagulation, and the November ultrasound showed thrombus in the posterior tibial vein again, as well as thrombus in the perineal vein. So December, the patient shows up at their primary care office with still swelling and pain in the leg. They've now been on anticoagulation for almost 3 months, and they're sending to vascular surgery for possible surgical intervention and other recommendations. So spend some time talking about venous thrombosis. When you think of the venous system, in addition to the deep and superficial, you should think about both the proximal and the distal segments. So the distal veins include basically everything below the popliteal, so gastrocnemius, the tibial veins, the soleal sinus are the predominant ones. I should mention that any of the tibials, the perineal, posterior tibial, and anterior tibial are all a paired venous system, and the gastrocnemius and the soleal sinus are single venous systems. Current chest guidelines say only look for distal DVT with a high pretest probability, positive D-dimer, or in the correct clinical context. And again, their recommendations are for patients without significant symptoms or high risk for extension. Recommend ultrasound over anticoagulation. So that's an ultrasound every week for 2 weeks total to avoid anticoagulation. So our patient had distal DVT and was started on an anticoagulation. If you look at the risk factors, the extent of thrombus is important. A lot of ultrasound labs won't tell you how much thrombus, but if you call them, they can give you an idea. So greater than 5 centimeters in length. If it's close to the proximal vein, so generally it's the popliteal that they're draining into. So within 2 centimeters would be a high risk feature in my mind. If there's no reversible provoking factor, so this is a de novo in a patient who hasn't had recent surgery and who's fully ambulatory. Active malignancy and COPD are risk factors due to their hypocoagulable conditions. If they're highly symptomatic or they don't want to have repeat ultrasound imaging, you can anticoagulate them, and you're basically treating them as a proximal DVT for 3 months, usually with a DOAC. If you have a proximal DVT, if you don't have a contraindication, they recommend 3 months for anticoagulation. Again, chest guidelines. If you have a major transient risk factor, they think 3 months is adequate. You don't need to extend. If you have an unprovoked DVT or you have a persistent risk factor, consider extending phase with your DOAC. And then if you're extending your phase of anticoagulation with a DOAC, the caveat there is that there really isn't a lot of data supporting length of duration for that extended phase, but you should reduce your dose of your anticoagulant in that setting. Weak recommendation in terms of a treatment strategy, in terms of pharmacomechanical thrombolysis to get rid of DVT. And really, that comes down to the fact that treatment with a mechanical or an intervention is really about long-term health of patients, and they didn't find that provided that much benefit over just anticoagulation alone. And of course, there's a risk involved with an intervention. Occasionally, patients will get PE protocol CTs. If your PE protocol CT comes back with subsegmental PE, and the radiologists usually put that in their diagnosis, current chest guidelines say surveillance over anticoagulation. So these patients don't need to be put on full anticoagulation or don't need to be anticoagulated for life as well, unless they have a high risk of recurrent VTE or if they've got clot in their lower extremities, for which you would anticoagulate them anyway. So kind of in summary, other things that I see from patients that we've had discussion about is anticoagulation does not produce thrombolysis. So just being on a DOAC is not a mechanism for getting rid of the clot. Really, the reason why you're on a DOAC is to prevent additional clot propagation. Follow-up imaging isn't necessary as it's really not going to affect management in patients. You're making a decision on the front end as to length of anticoagulation based on their current clinical context, and a follow-up ultrasound at 3 months or at a month really isn't going to do anything, because you should continue with your management strategy. You shouldn't alter the care plan unless something significant happens from a clinical standpoint. Switching gears a little bit, talking about lower extremity arterial disease. So you get a new patient in your clinic, they have a history of peripheral artery disease, and you get this ultrasound, which looks maybe a little bit concerning. Shows a couple areas. There's a tibial artery that looks occluded. It looks like there's some disease in the proximal superficial femoral, and they've got a previously placed stent. ABI is pretty low at 0.41, and their waveforms here look monophasic. So clearly this patient has peripheral artery disease. Referral is appropriate for management, but we'll spend a little bit of time talking about the larger context and really what needs to happen for this particular patient. So just by way of demographics, lower extremity peripheral artery disease is generally a disease that happens in older patients, starting around age 50, and grows as people age as well. You can see the prevalence of any peripheral artery disease in the 70 and older population is 14 or 15%. On the right, you can see the graph looking at patients with symptomatic peripheral arterial disease, predominantly claudication. And again, starting at age 50, that number starts to grow, and you're looking at 7 or 8% when you get into the 70s for patients with peripheral artery disease with symptoms. And by that, I mean, you can have peripheral artery disease, which basically shows either an abnormal ankle brachial index or greater than 50% narrowing, which is defined as hemodynamically significant in patients, even if they don't have symptoms such as claudication.
Jose, we have a question from Dr. Kennedy here.
Perfect.
Oh, yeah, just a quick question if I could. Thank you.
Yeah.
On the demographic, so the males are higher all along the way. Is that entirely accounted for by smoking or cholesterol levels or activity?
So I think generally men tend to have higher rates because of their comorbidities, for sure. But the females aren't too far behind, and certainly as they get older, the females actually at the 70 and older are above the men. So the distribution is, I would say in clinic, anecdotally, I would see more men than women, but I think it's mostly driven by risk factor. Agree with that. Thank you for the question. If we look at the contributing factors for peripheral arterial disease, on the left, there you can see gender as an independent risk factor. We talked about age. The two big ones really are diabetes and smoking, and this doesn't come as any surprise, I would expect, because peripheral arterial disease is essentially an extension of coronary artery disease. It's just a different vascular bed. Race plays a role. I had a couple of race slides which shows affects blacks more than whites or Asians, and as an ethnicity, Hispanics. And then renal insufficiency plays a role, and especially when you get into end-stage renal disease, those patients, their vasculature is particularly hard affected by their kidney disease. On the right, if we look at risk factors for developing what used to be called CLI, it's now in the literature CLTI. Again, diabetes and smoking are the ones that really play the largest or disproportionately the largest role in terms of developing that. And these patients are ones that have limbs that are now at risk. Probably one of my favorite slides in the entire thing, mostly because peripheral artery disease is very prevalent, is very relentless. And I think that in my career, as I've spent more time trying to tell people about what happens to them with this disease process, it really is an eye-opener when you start to sketch this out. But what we can see are these asymptomatic patients in the whole PAD patient population make up almost 50%. Claudicators are probably the largest proportion. And then critical limb ischemia is a small percentage at 1 to 3%, but certainly the ones with the most to lose. I tell all claudicators this: claudication is a quality of life issue. Treatment for claudication is really to allow you to walk farther without pain. There is no data that says that treatment of claudicators will, in fact, preserve their limb. And in fact, there's probably some data that shows, or I've seen a couple of abstracts that say that treatment of claudicators actually puts their limb at risk for amputation in the future, because any intervention we perform has a limited lifespan. And if that intervention goes down, and we're unable to rescue them in some contexts, they may face amputation. If you look at the claudicators, their 5-year outcomes with regards to their limbs, 10 to 20% will worsen. Majority of them will remain stable if you can medically optimize them, and only 5 to 10% will fall into the critical limb ischemia pathway. In terms of their morbidity and mortality, over 5 years, 10 to 15% will die, and the majority of them, again, will die as a result of a cardiovascular cause. If you look at the critical limb ischemia patients, the 1-year outcomes are uniformly not great. So 25% of them will be dead at a year. That's the patients will show up at your office with an ulcer, gangrenous toes, or rest pain, which is defined as pain on the dorsum of the foot, can extend more proximally, but has to be the dorsum, present for 2 weeks, improved only with opioids, frequently wakes them up from sleep at night and causes them to hang their leg off the side of the bed. PAD effect on mortality. So your asymptomatic patients, you have an increased risk of mortality relative to those patients without peripheral arterial disease, 1.5. And then when you get into the symptomatic patients, their risk of mortality compared to their cohort without peripheral artery disease is twofold. So certainly, doing everything possible to medically optimize these patients should affect their lifespan as well. So medical therapy for peripheral arterial disease, really 3 components: lifestyle modification, good blood glucose control, smoking cessation are the cornerstones there, healthy diet as well, medications, we'll talk about that for a couple seconds, and then a structured exercise program. So medical management, as put forth by the American Heart Association, antiplatelet agents, aspirin or clopidogrel, and these are really cardioprotective effects. The Capri study showed a benefit, especially in PAD patients, risk reduction of 20% compared to controls in patients who were taking aspirin and clopidogrel together. The overall cohort, which included patients with stroke and with coronary disease, had a more modest effect. But I thought that 20% was a pretty impressive number, and so I generally counsel PAD patients to consider taking both. They should all be on a high-intensity statin until they hit age 80, and after age 80, any statin is acceptable according to the AHA. May consider low-dose rivaroxaban, 2.5 milligrams twice daily for cardioprotection. More recent study came out that looked at that. I was surprised that AHA recommended that much more than the aspirin and clopidogrel, because initially when the Capri study came out, the reason why they didn't endorse clopidogrel more vigorously was because of the costs associated with that. And I think that rivaroxaban is in that box as well, where it can be expensive for some patients. And then cilostazol for high-risk patients with decreased quality of life and limited revascularization options can potentially help them walk further. Contraindications to that are patients with congestive heart failure. Statins probably know most of this, but the adverse effects, myopathy, diabetes over time, liver-induced issues, and memory loss, most of them are reversible by cessation of the statin. But I tell patients that besides the lipid-lowering effects, the things that I think about with statins are decreasing the inflammatory response and stabilization of the plaque to prevent plaque growth over time. So back to our prior patient. With this ultrasound, in my mind, peripheral arterial disease is really management of symptoms. So if this patient has no complaints of claudication pain and has no tissue loss, that patient can continue to be surveilled. If they have claudication, we'd work on medical management or medical optimization. If they've got tissue loss, then we need to talk about improving their blood flow to get it to a point where they will have a high likelihood of wound healing. Exercise for intermittent claudication. There is a real and demonstrable benefit. So there are two distances we talk about. There's a pain-free walking distance and a maximal walking distance. And you can see the exercise group, so started off between 116 meters to 413 meters, and they were able to walk pain-free an additional 82 meters with supervised exercise over 3 months. And their maximal walking distance increased to 120 meters over the no exercise group. There are a bunch of apps out there now. This is just one of them, peripheral vascular disease, or the PAD tracker. You can download it to your smartphone, and it will basically track how far you walk every day. And it's kind of a good way to allow people to see how they're doing with the walking program over time. So when you see a patient who you think has claudication, there's certainly a lot of other things that can cause leg pain or leg symptoms, ranging from Baker's cyst to venous claudication, chronic compartment syndrome. I would say chronic compartment syndrome is generally in younger patients. The two that I generally struggle with are, or see a lot of crossover, are patients with spinal stenosis or nerve root compression. Both can decrease people's walking distance. The things that I try and use to differentiate the two include the amount of time that people require for relief of symptoms. Typically, claudication, kind of by its mechanism, requires a few minutes of rest, because really, when your muscles, and especially your calf muscles, are exercising and the demand for oxygen exceeds the supply and they start to produce that lactic acid, that's what really shuts down their ability to walk. So after a couple of minutes with their muscles at baseline and just needing that baseline level of oxygen and that lactic acid getting washed out, they feel pretty good. People who have neuropathic etiologies in general require longer periods of time to recover, 10 to 30 minutes. They almost always need to sit down to recover. And the other thing that you see here, if they're just standing in place, they can develop symptoms that prevent them from standing for long periods of time, more than 5 or 10 minutes. And so when you're just standing and you're not really requiring that much oxygen, or you're not increasing your oxygen demand, again, I start to think about these other etiologies. And then obviously musculoskeletal arthritis are the things to consider as well. So what about that patient you're just not sure? What else can you do in terms of evaluation? So I like to get a pre and post exercise ankle brachial index. And what they do is they basically take your ankle brachial index before putting you on a treadmill, exercise you for 5 minutes, and then reevaluate. And if you have an occult stenosis, that ABI should decrease by about at least 0.2. So here's a patient with a pre of 0.94 and 0.97, which is normal at rest. You exercise them and they drop to 0.68, 0.61, which says that there is a hemodynamically significant stenosis that decreases the blood delivery after exercise. And they also come with these waveforms. So these waveforms look pretty normal at the intertibial and posterior tibial in both the left and right sides. If you look at it without the exercise ABI, you may miss a stenosis that potentially could be treated to improve somebody's quality of life. In terms of interventions, just a reminder that our interventions are not perfect. At 2 years, we're looking at about 60% primary patency, or patency that didn't require some other repeat intervention, ballooning or angioplasty. And these are for drug-coated balloons or drug-eluting stents. When we talk about limb salvage, this is older data, but there's actually a new BEST trial that came out. Balloon angioplasty and bypass surgery preserved similar numbers of limbs in patients when you used a balloon first strategy, or a percutaneous first versus an open first strategy. When you look at survival over time, bypass surgery actually had an advantage. So if you expect people to live 2 or more years, you should probably offer them open bypass surgery rather than a percutaneous intervention, despite the additional work effort required for the open surgical procedure. Switching gears, talking about cerebrovascular disease. So screening is certainly pretty important. But if you're looking for greater than 50% stenosis, which is hemodynamically significant, screening general populations does not turn out to be particularly effective, even if you're looking to identify 20% of people. So they recommend against this. This is the Society for Vascular Surgery. Really what you're doing is looking for patients with risk factors for atherosclerosis. So you're basically saying people who have atherosclerosis and other vascular beds are reasonable candidates for screening. And part of that comes from this Western New York stroke screening program, where they tried to set up a selection criteria. And what you can see on the left here is that age is probably the biggest predictor, which is kind of what we saw in the peripheral arterial disease patients as well. Being male has less effect, active smoking, and then other things that you would expect for arterial disease, coronary disease, and hypercholesterolemia. So they put that all into a chart, and if you got an intermediate score, you're going to have a post-test probability of a 1 in 5 chance of having greater than 50% stenosis in a carotid bed. And again, here's just the high-risk groups. So what you kind of would expect: people with prior arterial disease and other vascular beds, people over age 55, again, you're getting age, and then their risk factors, either smoking or hypercholesterolemia, hypertension, diabetics, people with aneurysms, as aneurysms are part of that. So you've identified a patient who needs screening, and you get this ultrasound that comes back, and they summarize it as plaque at 50 to 69% stenosis on the right side, and the left side looks pretty good. And then they say there's a right vertebral stenosis. So you refer that patient along to vascular, and here's kind of what our thought process is. So for asymptomatic patients who are good surgical candidates with greater than 70% stenosis, recommend surgical intervention to prevent risk of stroke in the future. Most of that data came, or the basis for that data came from ACAS, which is now a pretty old study from back in the 90s. But basically, best medical therapy, 11% risk of stroke. Surgery decreased that risk down to 5.1%. The big complaint about that was statins. Here's a study that was a prospective randomized study that looked at statin use over time. So this is ACAS time, and then through 2007. So you can see the majority of patients by the end were on statins. And then when they looked at statin use in the surgery versus medical arms, what you can see is that there's still an advantage conferred to surgical intervention. And these time points are actually at 5 and 10 years. So you're extending it out further, but you're still reducing that risk of stroke over time. When you have an asymptomatic patient with greater than 70% stenosis, I still think about a bunch of other things which kind of guide my decision to offer surgery. Life expectancy: if you're not going to live 5 years, you're not going to benefit from surgical intervention. Age: from all the major randomized trials, the data set is pretty limited after age 80, so that's a very personalized and individualized discussion. Gender: we know that men tend to derive more benefit from endarterectomy than women, but again, women were generally pretty underrepresented in most of the major randomized studies. Functional status: if you had a prior stroke with a pretty significant deficit, you're not really preserving that much brain matter, and so surgery is probably not great in terms of a risk-benefit ratio. And dementia, as it plays a role in terms of people moving forward. Endarterectomy is very different than any other vascular surgery, whether it's coronary, lower extremity, because really we're not trying to improve blood flow to the brain to improve cerebral perfusion. We're trying to prevent embolization from occurring. And so endarterectomy in demented patients, isn't going to improve their memory status. Their cardiac function certainly plays a role. If you have a patient with a decreased ejection fraction makes them a higher risk for surgery, similar with a pulmonary disease patient. Probably not going to be a great candidate. And then renal insufficiency, certainly patients with end-stage renal disease do uniformly poorly and should not be offered surgical intervention for asymptomatic disease. And there are a couple of calculators you can plug all this stuff into to look at their risk of a perioperative event and compare that to the benefit from surgical intervention. Back to the screening ultrasound. So what about the vertebral arteries? So this was something that I've seen increasingly in my clinic. Patients will come in with an isolated vertebral stenosis, referred in for evaluation. So you got to understand a little bit about the vertebral anatomy. So vertebral arteries are divided into 4 segments. V1 comes from the subclavian, and it's before it enters into the vertebral canal. The V2 segment goes through the vertebral canal, and then the V3 is after it's exited the canal and before it enters the brain for the posterior circulation. And the V4 is the intracranial part. When you look at it, so the V1 segment, which is generally where they're telling you the stenosis is located, the most common place for atherosclerosis to develop, can develop in 20 to 40% of patients. Lesions are usually smooth and flat and don't really kind of look like or function the same as atherosclerotic plaque in the carotids. V2 generally doesn't develop plaque, but this is the area where you should be kind of evaluating with ultrasound. The other thing I'll say about V1 and ultrasound is there's going to be some turns and some tortuosity there. And we know that tortuosity tends to increase velocities falsely. And when they're talking about a stenosis, there's actually no ultrasound criteria that determines a hemodynamic of a stenosis with regards to vertebrals as opposed to the carotid. So when you're thinking about these lesions, from an embolic standpoint, really surgical or endoluminal, so stenting, is warranted if medical treatment fails, but it is not indicated in asymptomatic patients who present only with radiographic findings. So if you have a patient who doesn't have evidence of a stroke, but has a stenosis on the vertebral, I tell them that there's nothing that needs to be done. You don't even need to surveil it. You should be medically optimized, and that's kind of the extent of treatment. Vertebrals just don't embolize and cause strokes nearly as often as carotids do, and the data set for prophylactically treating them, in contrast to an asymptomatic carotid, just isn't there. So in summary, screening for asymptomatic patients, really age is the biggest one, over 65, and then if they've got risk factors or identified vascular disease. Selective patients will benefit from endarterectomy, but again, risk benefit has to be individualized. All symptomatic patients should be referred for evaluation, and the criteria there is actually decreased to 50% or more for carotid stenosis, and the best benefit comes from intervention within 2 weeks. I've seen a couple of patients recently who've had like amaurosis events. Last one was a month ago, and are just getting referred across to vascular. If I see a referral for a patient that looks like they're symptomatic, I usually try and put them on the priority list and get them seen within a week to have a discussion about intervention strategies. And then finally, in the last couple of seconds.
Hey, Jose.
Yep.
Jose, this is Mark. I have a question real quick.
Yeah.
Over these recent years, given time constraints, productivity issues and stuff in primary care, the quote routine physical unquote has evaporated to some degree or to quite a bit of a degree. And you sort of wonder in the physical of a primary care visit in an elderly asymptomatic person, well, what do you examine? What don't you examine? Do you know if there's any data to suggest that quickly listening to the carotid arteries might have a good upside given the time constraints of office visits?
Yeah, that's a great question. So the data that I know is that is that the correlation is about 35% with carotid bruit and symptomatic lesion. I would say that is probably an underutilized part of the physical exam. But I think a lot of it comes down to clinical context, right? If you have a healthy patient who's not a diabetic, who's never smoked, and who's 75 and has been kind of managing everything pretty well, the likelihood that they'll have a bruit is going to be pretty low. Whereas if you have a pack-a-day smoker who is generally medically okay, but not the best, it's going to be higher. But I think I didn't mention it, but SVS does say if you did detect a bruit on physical exam, that's another indication for getting a carotid duplex.
Thank you.
Yep, no problem. So aneurysms, real quick, the biggest risk factor for an aneurysm is going to be smoking. After that, family history, and then any of the other arterial disease processes. Sure, everybody knows, one-time ultrasound for men or women 65 to 75 with a history of tobacco use is defined as 100 cigarettes in their life. And then surveillance screening after that is if it's below 3 centimeters after 10 years, if it's 3 to 3.9, 3 years, and then once it gets to 4, it's annual, and then after 5, it's every 6 months. I think that this is reasonable because the rate of growth is going to be 1 to 3 millimeters per year on average. And so at 3 to 3.9, an annual screening isn't going to show very much, or there's not going to be much growth. Problem with that is that I think that patients tend to fall off the radar at 3-year intervals. When you look at rupture risk, that rupture risk starts to go up right around here in the 5.5 centimeters, and that's generally the accepted rate of repair for men at 5.5 centimeters. Women a little bit lower because their natural aortic size is a little bit smaller at 5 centimeters. This is just looking at UK small aneurysm trials. So if you find a smaller aneurysm, why not fix it sooner? And the answer is that because these patients have comorbidities that cause them to expire of other causes, and really surgery versus surveillance kind of equalize moving forward. Repair strategies, open versus endovascular, a lot of it is dictated by anatomy, and most of the anatomy is up here at the neck, just below the renal arteries. So if you don't have enough length for a seal, or if the diameter is too great for an endograft, then you're looking at open surgery. But by definition, complexity with open surgery for non-endovascular candidates dictates increased risk, mortality, renal dysfunction, cardiac complications, and pulmonary issues. So last thing, patients with saccular aneurysms are supposed to be repaired regardless of size. So this is a patient that had been followed for a bit and then got referred over. The infrarenal aneurysm was a little bit smaller than the size criteria at 5 centimeters, but he had this saccular component. You can see that the distance from here to the renal artery was pretty small, but we ended up basically creating a fenestrated endograft. So it's kind of custom made based on the size that we sent. So they cut a hole here for the left renal artery and cut a hole in the graft for the right. You deploy the endograft, and then you cannulate both of those and put in a couple of stents to situate the graft and kind of seal things off. And that was the result. So that saccular component has now kind of been excluded on the completion angiography. That is pretty much it. From a venous standpoint, more conservative therapy, less anticoagulation, lower extremity, peripheral artery disease. Really, I think symptoms dictate management, with the exception of the fact that everyone should be medically optimized. Cerebrovascular, I think that endarterectomy or transcarotid stenting in appropriately selected patients. There is a CREST-2 coming out looking at asymptomatic patients. and transfemoral stenting and those same patients versus open carotid surgery with medical optimization. So that data set is probably going to be coming out in the next 1 to 2 years. And then abdominal aortic aneurysms, certainly risk factor modification. Again, it's kind of the common theme, smoking cessation, and then intervention at appropriate size. So I hope that provided people with some insight in terms of disease processes, when to refer, and maybe doing a bit more workup yourself. Thanks for your time and attention.